Psychiatry traditionally treats pathology as a chemical or cognitive deficit existing entirely within an isolated brain. The observer-embedded reality framework models the mind as a receiver situated within a continuous flow of information, a coherence field. Standard diagnostic manuals reinforce this by categorizing complex conditions as isolated checklists of symptoms, overlooking the underlying structural failures of the system. This framework suggests that the human mind is structurally embedded within its environment, functioning as a coherence detection apparatus. Stable function depends on three geometric components: a central anchor to own the experience, a visibility window that sets the range of perception, and the incoming data of the coherence field itself. Mental illness represents a structural failure in how this receiver integrates its reality. We often describe dopamine as the brain's pleasure chemical, a heuristic that obscures its mechanical purpose. Dopamine functions as the signal carrier for predictive salience. It is the biological mechanism that registers when a meaningful pattern is detected in the environment. When dopamine depletes, meaningful events in the coherence field continue to occur, but the observer's receiver drops the signal. The information is present, the capacity to register it is gone. We can test the limits of this architecture by observing how its geometry breaks in three distinct ways. Mapping these failure modes allows us to design interventions that address the specific structural breakdown. Depression manifests as coherence collapse. The central anchor remains stable, but the visibility window narrows into a restrictive slit. This visibility narrowing forces positive future possibilities to fall outside the observer's detection range. The information is blocked by the architecture of the aperture itself. The system then enters a tractor lock. It settles into a self-sustaining configuration that absorbs incoming signals without shifting its pessimistic baseline. As the collapse deepens, the observer loses the structural capacity for empathetic coupling, preventing them from borrowing coherence from the people around them. Pharmacological interventions like SSRIs restore the neurochemical floor to provide minimum signal capacity, but they leave the contracted window unchanged. Sustained therapy provides a reliable empathetic coupling event. This relationship functions as a structural wedge, incrementally prying the collapsed window open. Recovery involves the physical re-widening of the visibility aperture through exogenous relational scaffolding. Schizophrenia represents coherence disintegration. The central anchor dissolves, and the visibility window shatters. Coherence generation remains hyperactive, but without a central anchor, there is no stable reference point to integrate these patterns into a unified experience. Hallucinations and thought insertion occur when linguistic patterns arrive at the observer without the anchor signature required to identify them as internally generated. Acute doses of psychedelics are contraindicated here because they further destabilize existing anchors, which amplifies the disintegration. Denny Cho proposes a paradoxical intervention using a subperceptual longitudinal titration protocol. This protocol utilizes use-dependent plasticity by applying sub-threshold loads of psilocybin over several months. This microdosing schedule exercises the anchor's integrative capacity without overwhelming it, slowly building the stability the system lacks. The therapist acts as an external anchor scaffold, maintaining a stable reference for the observer while their internal architecture is being constructed. Building stability in an unanchored mind requires micro-increments of load rather than permanent suppression. Pathological overcoherence occurs when the drive for internal consistency overrides the capacity for external error correction. This creates a local coherence singularity, suppressing contradictions as meaning density reaches a critical limit. Because the observer organizes their internal model, any compression inevitably places the self at the center. As the lattice solidifies, the observer becomes the entire structure's central axis. This results in extreme internal clarity that is misattributed to external grandiosity or personal exceptionality. This chart shows the paradox of the coherence boundary. As internal coherence peaks, the external validity of the model plummets. The singularity demonstrates that an embedded observer cannot self-verify. Absolute subjective certainty often signals total reality detachment. These failure modes, collapse, disintegration, and overcoherence, are variations of the same underlying architecture. An observer trapped inside a failing geometry cannot restore their own architecture from within. All three conditions share a requirement for exogenous scaffolding, external intervention that provides the structure the observer cannot maintain alone. Healing involves lending architecture to the system, whether through therapeutic connection or carefully calibrated pharmacology. The future of clinical intervention is structural repair for architectures that have been unbuilt, contracted, or trapped.